Okay, so the rest of this module, we're going to go over some reproductive medications, some hormones that exist in males and females, the differences between them, some medications that are used for BPH, benign prostatic hypertrophy. So we'll just slowly go through this and make some sense of it. Okay, so estrogens as a prototype. So there's many one of estrogens on the market. So let's just get an idea of what an estrogen is. Now, one of the main female hormones is estrogen, the other being progesterone. And we often want to use estrogen for different medical conditions. So it comes in pills, it comes in patches, it comes intravenously for different indications. So let's look at some of the more common indications for estrogen. Definitely when it's combined with progesterone in a pill or a patch, it's very effective as a contraception. So a contraceptive pill, birth control pill. As well, it's used in combination with progesterone to control acne in young females. So another indication, so someone who wants the contraception and also has acne, there's certain birth control pills that have the indication for obviously birth control and also for acne. We use estrogen in postmenopausal women for menopausal symptoms, hot flashes, depressive symptoms, night sweats, all kinds of symptoms that postmenopausal women can get. The other thing that postmenopausal women can get, or if you're a female that for whatever reason had ovarian failure prematurely, like say at the age of 40, or you needed to have your ovaries removed, then you would go on to estrogen therapy. And one of the main reasons to go on to estrogen therapy, postmenopausal, or if you've had ovarian failure, is to prevent bone loss. Because once the estrogen has stopped being produced in the body, such as a postmenopausal woman, bone loss accelerates. Okay, so estrogen stimulates and maintains the bones in women. So osteoporosis really accelerates after, or can become very common after menopause. Estrogen also maintains the tissue of the vagina, of the vulva, and without it, you can get all kinds of symptoms. You can get vulvar atrophy, which is thinning of the tissue of the female genitalia. You can get atrophic vaginitis, meaning the thinning of the tissue of the vagina that was maintained by estrogen. You can start to develop urinary incontinence postmenopausally. Another indication, we'll come back to the uterine bleeding in a minute, but another indication is if you're born with hypogonadism. So say you're a child and you've been diagnosed with a syndrome that causes reduced estrogen production, whether it's from your pituitary or from your ovaries. There's something that's causing estrogen not to be produced. Well, you would be a candidate for estrogen replacement. Uterine bleeding and uterine hemorrhaging. So sometimes women can have very abnormal periods, and they can come in with really heavy bleeding from what's called either dysfunctional uterine bleeding, DUB, that can actually lead to uterine hemorrhaging, so bleeding that just won't stop. And that is an indication for intravenous estrogen, because estrogen grows the endometrial lining. Okay, so it stabilizes and grows the endometrial lining. In particular, it grows it. Okay, so if someone's hemorrhaging, IV estrogen can actually stop the endometrial hemorrhaging. Okay, so what else is it going to do if we give someone estrogen? Well, there's a negative feedback to the pituitary, so it's going to turn off FSH and LH. It's going to stop the bone from being resorbed, so broken down by the osteoclast, because you're introducing estrogen. It's going to support and maintain the female reproductive tract, so to avoid atrophic vaginitis, which is dry, thin skin or mucosa in the vagina, which can cause painful intercourse. It can cause irritated vaginal mucosa, which can then lead to bleeding. And it's gonna maintain. It can potentially help avoid urinary incontinence by maintaining the tissue there as well. What are the adverse effects? So giving someone estrogen by itself is going to stimulate the endometrial lining. Okay, so we spoke about estrogen being it grows the tissue in the endometrium. So if you look at estrogen naturally, when it's made in the body as part of someone's menstrual cycle, the first few weeks are really predominantly estrogen based, and then after release of the ovum, it becomes estrogen and progesterone. So estrogen really grows the endometrial lining to prepare it for an ovum. So if you're using estrogen, say postmenopausally, or because you had ovarian failure, it will still grow that endometrial lining. Okay, and you don't want to stimulate the endometrial lining indefinitely, because whenever you stimulate something indefinitely, it puts you at risk to form endometrial hyperplasia and then finally endometrial cancer. There was also a study that came out about 25 years ago that showed that estrogen use in postmenopausal women put them at a slightly higher risk of breast cancer. And that's why a lot of estrogen was stopped in postmenopausal women, because of the small increase in breast cancer. So a lot of women had to go off it and endure menopausal symptoms because of that study. So not everyone went off it. It was a choice, right? But they were given the choice, and a lot of women were worried, and they stopped estrogen, what was called hormone replacement therapy, HRT. The other risk factor, or the other adverse effect with estrogen, so whether it's in a birth control pill or whether it's just taking estrogen postmenopausally, is increased chance of blood clots. Now this is vastly reduced in risk because we are using much lower dose of estrogen in birth control pills and also postmenopausally to control the loss of bone and reduce incidence of osteoporosis and also the menopausal symptoms. So it's still there though. And why does estrogen lead to blood clotting? Well, estrogen stimulates the liver to produce clotting factors, puts you at higher risk for clotting. So what's the contraindications for estrogen? Well, smokers who really wanted to be on the birth control pill we were very careful with, because smoking thickens your blood and it puts you at risk for DVTs and PEs. And so smoking combined with a birth control pill or with estrogen is even a higher risk factor. So smoking is considered a contraindication. Pregnancy, well, you wouldn't take estrogen if you're pregnant. You're making lots of estrogen already. Heart disease, there was a small link to increased cardiovascular disease, and I think it was primarily the vascular part, which was increased clotting risk. Okay. You wouldn't use estrogen in someone who hasn't reached puberty, a female who hasn't reached puberty, unless they had some kind of ovarian failure, because estrogen is partly responsible for closing the growth plates. So you wouldn't want to close a child's growth plates prematurely. Breast cancer that's estrogen dependent. So when somebody has breast cancer, we can test the breast cancer to see if it's estrogen receptor positive. And if it is, we actually use a medication called tamoxifen that blocks any estrogen from getting to the receptor to slow down the progression of the cancer. So we certainly wouldn't use estrogen in someone who either has a history of breast cancer or has proven estrogen positive receptors in their breast cancer. So in terms of responsibilities, discontinue prior to any procedure that causes extended immobility. Well, that makes sense because of the increased risk of clotting while on estrogen. Taking at the same time daily. That would be really important in terms of the birth control pill, right? Reporting menstrual changes. So if you have spotting and bleeding on the birth control pill, or if you have missed periods, that would be important to report. Could be pregnant. And also advising people about the risk of a potential DVT or PE, whether they're taking it as a birth control pill or for postmenopausal symptoms. There is a chance, especially if they decide to start smoking. And lastly, if you're using estrogen postmenopausally, or say for someone who had premature ovarian failure in their 30s or 40s, and they still have their uterus, which will be the majority of people, you can't give someone estrogen by itself. You need to give progesterone with it. And that comes back to the increased risk of uterine cancer if you just give estrogen by itself. The progesterone you can think of as a stabilizing hormone in the uterus, and it matures the tissue. So estrogen grows the tissue to prepare for a pregnancy. I'm talking about a menstrual cycle here. And then the egg is released, and then the second part of the menstrual cycle, progesterone starts to be produced. And this matures the tissue, stabilizes the tissue. Okay, so it reduces the chance of endometrial cancer, and that's why we use it in combination with estrogen if you needed to be on estrogen and you had a uterus. I hope that makes sense. So this is really just showing that where did we get estrogen from? Well, the brand name for estrogen is Premarin. Well, Premarin is, so that's a horse, right? A pregnant horse. So Premarin was obtained from the estrogen of a pregnant horse. And just remember, we're talking about external uses of estrogen, meaning we're giving it as a medication. We're not talking about the estrogen cycle. Even though I'm referring to it sometimes, we're talking about estrogen as a pill or as a patch or intravenously as a medication, whether it's for birth control pill whether it's for postmenopausal symptoms, or whether it's to prevent osteoporosis postmenopausally. We're talking about giving someone estrogen, just to avoid confusion. Okay, so what about progesterone? So we can also use this in a pill form. We can also use it as an injection. So progesterone is the other female hormone, and in birth control pills, we definitely combine estrogen and progesterone. If you just gave estrogen to someone, not only would it not be good for their endometrial lining, because it would grow and grow and grow, and finally it would just bleed, because you didn't have the progesterone to mature it. So it's always added to birth control pills in combination with estrogen. Menopausal hormone therapy. So it would be added to the estrogen in menopausal hormone therapy if the person had a uterus. So let's just say someone had a hysterectomy and they don't have a uterus anymore. Well, then you can just give them estrogen by itself because there's no uterus to stimulate. Okay? What about this term dysfunctional uterine bleeding? So that term really refers to someone who has very irregular bleeding, heavy periods between their regular periods, very irregular periods to begin with. Like say they have a period every 6 weeks or 2 months, and they're heavy and cramping. So progesterone can be used, can be given to them, because hopefully by now you understand that progesterone is a stabilizing and maturing endometrial hormone. So we can give someone, say, a week or 10 days of progesterone to stabilize their endometrial lining, stop the progesterone completely, and we only gave progesterone, and then let them have a full withdrawal bleed. Okay, so let them have a full period. So let me say that again. Someone with irregular periods, they're having heavy periods and cramping, and we just want to do a reset of the cycle. We can give someone 10 days or 14 days of progesterone by itself, stabilize the uterine lining, stop the progesterone after 10 or 14 days. They'll have a full withdrawal period, and hopefully the cycle will return to a normal cycle. Okay, so that's we do sometimes do that with progesterone. So endometriosis. So endometriosis is a condition where endometrial tissue is living and growing outside of the uterus, so outside of the endometrium. So it can be stuck on the fallopian tubes, it can be stuck on the ovaries, it can be stuck on the bowel, all these places outside of the endometrium. And estrogen can aggravate it because it makes things grow. It's going to make that tissue grow as well. Progesterone, being the stabilizing hormone, the maturing hormone, can stop it from growing and just maintain it. So it can control the symptoms of endometriosis. Okay. Sometimes progesterone is used to prevent preterm birth. Sometimes women are diagnosed with low progesterone levels and they recurrently have miscarriages. And progesterone is sometimes used to prevent that. In vitro fertilization, well, that's fertilization outside of the body, so you'll need hormones to help with the fertilization. Okay, so actions: sex hormone involved in reproductive development and menstruation. Yeah, so now there's also birth control pills that are only progesterone. So Depo-Provera, under similar there, medroxyprogesterone is an injectable progesterone that gives 3 months of birth control effect. So it can be used in isolation. And why would we do that? For someone who, for example, isn't very compliant with pills and they forget their pills all the time, someone who just doesn't want to recall having to take their pill every day, or someone who can't tolerate the estrogen component of a birth control pill. Okay. What about the adverse effects? So breakthrough bleeding. So, I mean, some of this just depends on the balance of how much estrogen and progesterone you're providing, and if it's enough to maintain the endometrial lining. And if it isn't, then you'll get breakthrough bleeding. And for example, women that go on to the birth control pill, they're often given one particular birth control pill for 3 months. And it's not uncommon to have breakthrough bleeding or spotting in the first 1, 2, or 3 months. But typically after that, the birth control pill should provide regular periods once you stop taking the birth control pill. And then you have your withdrawal period, and then you begin the pill the following month. But sometimes it doesn't work that way, and you have continued breakthrough bleeding. And that's when it's time to follow up with your healthcare provider and talk about a different pill. And a different birth control medication. And it just depends on the amount of estrogen, the amount of progesterone, and the individual person. Okay. Amenorrhea. So if you took the birth control pill without having a withdrawal period, you would have amenorrhea. It has estrogen in it, it has progesterone in it. The body actually thinks you're pregnant. It's turned off FSH, it's turned off LH. So you would just not have a period, right? So these hormones can cause amenorrhea just by the body thinking that you're pregnant. You have estrogen and progesterone floating in your bloodstream. Your uterus seems to have a proper lining. The FSH and LH are at very low levels, so you have amenorrhea. Breast tenderness is from the breast tissue swelling and edema, and that's a typical symptom, say, in early pregnancy. Women notice that their breasts are tender, and it's from the hormones. Jaundice is because these hormones, including progesterone, stimulate the liver. Estrogen does. What progesterone does is actually it gives you a slowing down of the bile secretion. So it's called cholestasis. So slowing down of bile secretion, and that can lead to a backup of bilirubin, causing some jaundice. And progesterone can actually aggravate migraine headaches. Okay, so some women get terrible migraine headaches on the birth control pill. Okay, contraindications. In diabetes mellitus, I'm not sure if I don't think it's a contraindication. It can aggravate definitely patients with seizures, with migraines, and you would never use it in pregnancy, right? Pregnancy is it's being taken care of by the body with its own estrogen and progesterone. Now, in terms of responsibilities, you can definitely expect a withdrawal bleed if you've taken progesterone as a medication to do a reset of the endometrial lining, and then you stop it. And then there's a withdrawal bleed. Okay. The quarterly IM injection is referring to the medroxyprogesterone, the Depo-Provera, as a birth control pill. I mean, the one downside of Depo-Provera is that you can have side effects after the injection. So, and then you can't take back the injection. So most people tolerate it very well. It's just a thought at the beginning when you're getting an IM injection that it's not like you can go and just get it back, unlike a pill that you can stop very easily. Okay, so this slide is giving you a prototype oral contraceptive. So there's an estrogen and there's some form of a progesterone. So ethinyl estradiol is the estrogen, and norethindrone happens to be the progesterone in this combination. And by far the most common reason for using contraception in general would be to avoid getting pregnant. Definitely does not prevent STDs. There's some other indications though. If you are a woman that has heavy periods every month, so you have regular periods, but they're very heavy, and you become fatigued and tired, and you go for a blood test, and we find that your hemoglobin is 8.5. Well, you're not keeping up with the iron loss in the blood that's occurring every month. So we would definitely recommend that you go onto an iron supplement, but sometimes that's not quite enough because you're losing so much iron monthly with heavy periods. So heavy bleeding, but at normal times, is called menorrhagia. Okay, so you have regular periods; they're just very heavy. So a birth control pill can be used in that case to not change the regularity of the periods, but to control the amount of blood loss. It'll be much reduced when you're on a birth control pill, because the estrogen and the progesterone in the birth control pill will only build up the tissue so much in the endometrium, and then you'll have your regular period when you go off the birth control pill at the end of the month for those 7 days, and then you'll start the birth control pill again. So to reduce menstrual blood loss and also becoming anemic, we do use a birth control pill. Reduced cramping. So some women get severe menstrual cramps every month. They try ibuprofen. They try all kinds of anti-inflammatories because they can be effective in helping menstrual cramps. But sometimes women need to go onto the birth control pill to really reduce the menstrual cramps that are occurring every month. To protect against endometrial and ovarian cancer. So let's just go back a bit here. So the more that you cycle in the lifetime of all of your periods, starting from the time you started to begin menarche, say at the age of 13, all the way until you reach menopause, you're cycling every month. So you're stimulating the ovaries, you're stimulating the endometrium, and that runs a low risk, but it runs a risk of developing endometrial or ovarian cancer throughout your lifetime as a female. Birth control pills basically turn off the pituitary gland from stimulating the ovary, and they turn off the endogenous estrogen and progesterone in the body, and it's just supplying the estrogen and progesterone in the pill that you're taking. So you're actually reducing the number of overall cycles that you're experiencing, that your ovaries are experiencing, because you're turning them off. They're not releasing an egg every month. So if you're someone who has extremely strong family history of endometrial or ovarian cancer, one of the options is to be on a birth control pill. The other option, and this has been shown in studies, is that if you're women that have been pregnant many, many times have less overall risk because during their pregnancy they weren't cycling, right? They were pregnant. They weren't releasing an egg every month. So women with multiple pregnancies had a slightly lower risk of ovarian and endometrial cancer. Now, I don't think many people go on the birth control pill for this reason, but just to give you some history about why that indication exists there. Okay, so actions. Stops contraception by preventing ovulation. Yeah, right? It stops FSH and LH from being secreted by the anterior pituitary. Thickens cervical mucus. Absolutely. Progesterone does that. So it stops the sperm from getting into the endometrium. And altering endometrial lining to reduce the chance of fertilization. So, of course, the birth control pill doesn't act exactly the same as a woman's endogenous estrogen and progesterone. So, the endometrial lining won't be exactly the same to increase the chance of a fertile egg implanting. So lots of ways of preventing pregnancy. Thickening of the cervix, cervical mucus, reducing ovulation by blocking FSH and LH, and the endometrial lining is not quite the same. So adverse effects, these are basically all going to be blamed on estrogen. Thromboembolic events, that's DVTs and PEs, estrogen. Hypertension, estrogen. Don't smoke with a birth control pill. Increased risk of PEs and DVTs because of the estrogen. Breakthrough or irregular uterine bleeding can occur, and this is often because of the estrogen as well. So remember, the estrogen part of the pill is what grows the tissue within the uterus, and the progesterone is what stabilizes it. So if the estrogen content is too high in any particular pill, you'll grow the tissue too much, and some of it will start to break off, and you'll get irregular uterine bleeding. Okay? And often we have to change the birth control pill to adjust for that. Contraindications, well, pregnancy for sure, smokers for sure, greater than 35 is becoming a risk factor of increased risk of DVTs and PEs, history of any clots, such as a DVT or a PE, very high risk of breast cancer, likely not a good idea. Uterine fibroids are benign tumors on the uterus. They're not dangerous. Just that the birth control pill, because there's estrogen in it, will stimulate the fibroid to grow. So it may cause symptoms just because it's taking up more space in the pelvis. So it'll grow a benign fibroid to a larger size. And that's why after menopause, when there's typically no estrogen and progesterone, fibroids tend to shrink down and stabilize. Nursing responsibilities, so pregnancy test prior to starting, or the other option that we do is just start the first pill after the end of your period. So after the end of your period, you typically know that you're not pregnant. So if it's a predictable period and you've just gone through it, and starting the pill at the end of it, you know you're not pregnant. But the other option is to do a pregnancy test prior to starting. Definitely quitting smoking if you're a smoker. The cyclic administration, so the birth control pill comes in packages of 28 pills or 21 pills. If you get the 21-day pill, 21-day pack, well, they're all active, and then you go off them for 7 days, and you have your withdrawal menstrual period. If you get the 28-day pack, well, the last 7 days are just placebo. They're just sugar pills. And for people that don't want to forget to take a pill every day, they can get a 28-day pack, knowing that the last 7 days they're going to get their period because there's no hormones in them. Taking at the same time daily, mainly so that you don't forget. Missing more than 3 days, in a month in particular, it's going to become unpredictable in terms of the protection that it'll provide. And generally, you're going to start to get spotting through the month if you're missing pills, because if you're missing pills, the estrogen and progesterone will drop in the bloodstream, and the endometrial lining will start to shed, and you'll get a period. Okay, so if you know you've missed pills, then using a condom is a good idea, since you're likely not protected from getting pregnant. Okay, so this slide is on STDs, and just really a reminder that birth control methods, except really for condoms, are not effective in preventing sexually transmitted diseases. So really the only method is the latex condom that's been shown to reduce STDs. And if you look at the numbers here, chlamydia, so chlamydia is an extremely common bacteria that's sexually transmitted. Its name is Chlamydia trachomatis, and in men it doesn't give a lot of terrible complications. It typically gives you penile discharge, so kind of a clear jelly-like penile discharge in males. In women, sometimes you may not even know that you have it, because it can be within the vagina, very mild, clear discharge. It can actually give you PID, where it ascends into the uterus and the fallopian tubes and scars and damages the fallopian tubes. So pelvic inflammatory disease in women can be a result of any of these STDs. The next one, gonorrhea, which is from the bacteria Neisseria gonorrhea. In men, this is a bit more aggressive than chlamydia. This can give significant penile discharge, so very purulent pus discharge from the penis. It can actually ascend in the penis and cause some testicular issues and even epididymitis, which is a little sac next to each testicle that can get infected. In women, it can give a lot of vaginal discharge. It can also ascend in the female genital tract and cause pelvic inflammatory disease, which can permanently scar, again, the fallopian tubes, leading to infertility later in life. Syphilis, real name is, well, that is the real name, but the bacteria is Treponema syphilis, and this particular bacteria comes in stages. The first stage, or the primary, so primary syphilis that you see at the bottom there, that's the stage where you get the sores on the penis or within the vagina. In females, again, you may not see that unless the sores are external. In males, it's more obvious because it's already external, and that's the primary. That's primary syphilis, and they're typically firm. They're firm ulcers on the penis, and they're non-tender. And if ignored, they'll go away by themselves, and then you will get what's called secondary syphilis, which is typically lymph node swelling throughout the body, under your arms, in your groin, with a low-grade fever, and a typical rash that occurs on your body, on the palms of your hands, and the soles of your feet. So that's secondary syphilis, and that can go on. So once, if that's ignored or not diagnosed, you go on to a latent phase where the symptoms just go away, and then months to years later, you can be diagnosed with tertiary syphilis, and that's a much more aggressive disease. It can affect the brain in particular. It can give a lot of permanent damage compared to primary or secondary syphilis, which, if diagnosed, is very treatable with antibiotics. And congenital syphilis is acquiring it through birth. So these are all relatively common STDs. Definitely chlamydia is the most common. Okay, so let's move on briefly to some male-related issues and medications. So this slide that's saying male menopause or andropause, which is interesting. So males in their 50s and 60s can actually have a decline in testosterone levels, and we can measure that with serum testosterone, or even more accurately with what's called a free testosterone, a free serum testosterone, because most hormones in the body are bound to proteins. So in the serum, such as albumin and all kinds of different globins in the serum. So what we really want to know is the active part of the hormone. What is the free part that's not bound to protein? So we often will get a free testosterone or a free T4 level, and that gives us the exact amount that's actually just in the bloodstream without being bound. Okay, so let's look at some symptoms and complications of reduced testosterone levels. So decline in cognitive function or depression. So males can come in with depressive symptoms, and sometimes a testosterone level will be taken. There's definitely thinning of the hair and hair loss with being male, with having androgens, right? With having testosterone. Testosterone is responsible for maintaining muscle mass. So loss of muscle strength, loss of muscle mass can occur with diminishing testosterone levels. Increased fat mass and abdominal obesity. So testosterone tends to produce more muscle. Estrogen, which is the female hormone, tends to produce a bit more fat. And that makes sense because estrogen, so women are storing for potential pregnancy. So they may require that energy storage. Okay, I mean, males and females store fat, but I'm just trying to explain the differences between the um, the different sex hormones. Reduction in bone mass, osteoporosis, that can happen as your testosterone levels diminish. Reduced sexual desire, uh, shrinking or testicular atrophy from reduced levels of testosterone, right? Gynecomastia. Why gynecomastia? Well, when you have less testosterone in your bloodstream as a male, you still have some circulating estrogen that can be produced in your adrenal glands. So now the balance has shifted a bit more to estrogen, so you have the potential to have small breasts, gynecomastia. Okay, so these can all be symptoms of lowering testosterone levels in your 50s or 60s, and sometimes people will have low testosterone levels and are willing to try uh, testosterone as a medication to help their symptoms, right? And testosterone comes as a patch, as a pill, as an injection. So there's many options, there's many routes to administer testosterone. And that's what the next slide will be about. Okay, so testosterone as a drug. So it falls into androgens. Okay, so the main male and androgen is testosterone. Okay, so it can be used for hypogonadism, so small testicles or immature testicles that are non-functional. Testosterone can be supplied as a medication to supplement that condition. Delayed puberty in males. So if testosterone is felt to be the factor in delayed puberty, then it can be administered as a medication. And again, I think I mentioned before, pills, injection, or patches. And then probably the most common is as an androgen replacement for male menopause. Okay, which again, in your 50s and your 60s, there's potential. I don't think it's as common as female menopause, where the average age of 50 is when most females stop having their periods and stop producing significant amounts of estrogen and progesterone. So the actions of testosterone, well, it's a sex hormone. It's involved in reproductive development and maintenance of male sexual characteristics, right? So the muscle mass, the hair distribution, the I want to mention something about all of these hormones that we've been talking about, whether it's testosterone, progesterone, or estrogen. These are all steroid-based hormones, okay? And there's a lot of hormones in the body that are protein-based, but these are steroid-based, so they go into the cell and have direct action within the cell, compared to protein-based hormones or peptides. They tend to have a receptor on the cell membrane. Okay, sorry, I went off a bit there. Okay, so let's look at the adverse effects of administering testosterone to someone. Well, testosterone being the male hormone, there's potential for increased aggression when this is administered. In fact, there was a study years ago that went and did tests in many prisons and jails throughout North America. And it was found that a lot of the prisoners, I mean, a higher percentage, I shouldn't say a lot, but a higher percentage than the general population had a genetic defect where they had two Y chromosomes. So a male is usually XY and a female is XX. Well, it was found that XYY was found in a higher percentage in jails and prisons. And that makes sense. Two Y chromosomes, more testosterone production, higher and increased chance of aggression. Okay? As well, when you administer testosterone, acne, so facial acne, acne of the back, which can become what's called nodulocystic acne. So very severe cysts of acne can occur with testosterone, and that's why boys tend to get acne and severe acne much more than girls. Increased hair growth can be from administering testosterone to someone. Closing growth plates. So if you're giving testosterone to a younger child, it can close the growth plates prematurely. Okay, because testosterone is one of the hormones that starts to be produced at puberty, and it's partly responsible for closing the growth plates in males. Okay, just like progesterone, you can get a mild hepatitis. A cholestatic hepatitis, meaning the bile is not flowing well, and some of it's backing up into the bloodstream and giving you jaundice. Testosterone can mess with lipids, with your lipid profile, HDL, LDL. You can get abnormal lipid profiles that can be unhealthy. So you can get elevated LDL levels. So that's something to take into consideration, because that can lead to cardiovascular disease or put you at higher risk for cardiovascular disease. The next one, very important. Testosterone produced when given as a medication, or even if you're not taking it as medication, produced by your testicles, it stimulates the prostate gland. So when we give testosterone as a medication, we tell people you are at higher risk of developing prostate cancer because we're going to stimulate the prostate with this medication. And lastly, testosterone will stimulate the bone marrow to increase hemoglobin levels, polycythemia, higher hemoglobin levels in the bloodstream because of stimulation from the testosterone. Contraindications will definitely block prostate cancer. Breast cancer is relatively uncommon in men. If you had it, we wouldn't want to stimulate it in any way, so we wouldn't give you injections of sex hormones. But definitely prostate cancer, which is extremely common in males, if you have a history of it, or you have active prostate cancer, we definitely wouldn't give you testosterone. Congestive heart failure, because testosterone is an anabolic steroid, meaning it's going to build up muscle mass. It's building up more protein in the body. It's going to make the heart work harder. So if you have congestive heart failure, that's probably not a good idea, because the heart's going to have to work and produce a higher cardiac output. And then, of course, liver disease. Well, progesterone or testosterone can cause a mild hepatitis, so we would avoid it in someone with liver disease. So under responsibilities, yeah, definitely if you were handling testosterone, to wash your hands after, because it can get absorbed through the skin. Taking weights is important, because you will likely put on muscle mass with testosterone. And also patient education about the adverse effects. In particular, you're at higher risk of acquiring prostate cancer. You're at higher risk of higher levels of hemoglobin, of thickening your blood a bit by the higher hemoglobin levels. And you're at higher risk of abnormal lipids in your bloodstream because of the medication we're giving you. Okay, I hope that helps. Okay, so on to BPH, benign prostatic hypertrophy. So very common in males in their 50s, 60s, and 70s. So I usually think of the prostate as a small apple with the core taken out, and that's where the urethra goes, right? So at the top part of the prostate, or the small apple, is where the bladder sits. And at the bottom part of the prostate, small apple, is where the base of the penis begins. And the urethra starts at the end of the where the bladder drains into the prostate, so the prostatic urethra, and it continues all the way down the penis to the outside world, so the penile urethra. So normally there's a very open lumen inside the prostatic urethra, and urine has no problem getting from the bladder through the prostate, down the penis, and out. Because the prostate is stimulated and it grows through adult life, partly because of testosterone, but that's the reality of needing testosterone for other systems in our body. We end up stimulating the prostate and causing it to grow. And when it grows, it doesn't always grow in a cancerous way. It grows just in a hypertrophied way, non-cancerous sometimes. And it can squeeze on the prostatic urethra and lead to obstruction. And because you have an obstruction in the lumen of the prostatic urethra, you have reduced urine flow. So you can't empty your bladder very well. So let's go through a typical day of someone who has BPH. So let's start in the evening. So they have their meal, they drink something with their meal, they get ready for bed a couple hours later. They try to empty their bladder, but they can't because it doesn't fully empty anymore. And so what happens through the night? Well, they never really emptied their bladder, so they don't sleep through the night anymore. The bladder fills up much more quickly because urine was already left in the bladder. It never fully emptied. So they get up 2, 3, 4 times per night, and that's called nocturia. So having to urinate through the night, nocturia. And then they wake up in the morning, and the same thing kind of continues through the day, where they have a weak urine flow. Sometimes patients will dribble with BPH. They'll tell you that their urine flow is much weaker than before, and that they're getting up 2 or 3 or 4 times per night to urinate small amounts. Okay, so BPH is not a cancerous condition. Now, prostate cancer is also extremely common, but we won't talk about that right now. But let's look at some medications to treat BPH, as opposed to just heading right to surgery. Because the inside of the prostate can be cored out with a cystoscope, with a device on it, where it cores it out, almost like coring out an apple. But it's a surgical procedure. You tend to get quite a bit of bleeding with it. So, I mean, it's done frequently. It's called a TURP, so transurethral resection of the prostate. So transurethral resection of the prostate, a TURP. But there's medications that can be tried first. Okay, so let's look at a medication for BPH, benign prostatic hyperplasia, which is what we were just talking about on the previous slide. So finasteride or Proscar, which is a medication that stops testosterone from converting into an even more active form called dihydrotestosterone. So it blocks testosterone from becoming its more active form, dihydrotestosterone, which then stops it from stimulating, or because it's not being converted to this more active form, it's not stimulating the prostate as much, and it can gradually shrink it. So what about male pattern baldness? Well, if you can also reduce dihydrotestosterone with this drug, because it blocks the conversion of testosterone to dihydrotestosterone, well, you're not going to get as much male pattern baldness, because the male pattern baldness is from the dihydrotestosterone. So really, these are the two indications for finasteride or Proscar. So Proscar is the brand name for when it's used for the prostate, and Propecia is the brand name when it's used to grow a bit more hair and avoid male pattern baldness. So it has modest effects for increased hair growth. It has some, but it's not like you get a full head of hair back. So the action, just as we said, it reduces the usable testosterone, the dihydrotestosterone, and this will cause the prostate to gradually shrink in size, typically over many months, often 6 to 8 months. So it's not an immediate shrinkage, and it's not an immediate effect on benign prostatic hypertrophy and the difficulty urinating either. It can take many, many months. And the other action is increased hair growth by the same mechanism. So what are the adverse effects? Well, if you're reducing the active testosterone, dihydrotestosterone, then you could get decreased interest in sexual activity, decreased stimulation to the testicles, so that'll reduce the semen amount, the ejaculate volume, and also because you've reduced the balance between testosterone and estrogen, you've actually shifted it to estrogen because you've lowered the active testosterone levels. You can get some breast swelling from it. Contraindications, well, definitely pregnancy. Actually, well, no, I shouldn't say women never take this. Women do take this for a particular reason. Women with abnormal hair growth can be offered this drug to see if it can cut down on their abnormal hair growth. But definitely not in pregnancy would you take this drug, or in any kind of liver disease you wouldn't take this. So responsibility. So this is a long-term treatment for BPH. It's not an immediate solution. It can take, as I said before, half a year or longer to start to shrink the prostate. And I think that's all we'll say about finasteride. Okay, so don't think of it as a quick fix for BPH and the symptoms that go along with it. Okay, so the next drug we're going to review or discuss is tamsulosin, or the brand name's Flomax.
And you've seen this group before. These are alpha-1 blockers, prazosin, terazosin, and they're used for blood pressure control, right? They block the alpha-1 receptor in the blood vessels, in the small arterioles, and vasodilate the systemic circulation. So tamsulosin will still do that, but it is used as well for its other effect, which is to relax the smooth muscle in the prostate, in the bladder neck, and allow for increased urinary flow. So it'll still lower blood pressure, but it's been marketed more for benign prostatic hypertrophy because of its other alpha-1 antagonist effect. So really, because of how it works on the blood vessels is where you're going to see uh, the adverse effects. So potential hypotension, dizziness. Well, dizziness in this case, we're referring to that your blood pressure is dropping. Orthostatic hypotension. So when you get up too quickly, the blood doesn't have time to reach your brain, and you get orthostatic symptoms and dizziness. First dose phenomenon, where the first dose is a bit unpredictable in terms of how much power and how much effect it's going to have on your system. In problems with ejaculation. So we can talk about this just so it's easier to remember. It's an alpha-1 blocker, so it relaxes the smooth muscle in the upper prostate and the bladder neck, so it doesn't allow that valve to close as easily, which is great for urinating. But when you ejaculate, the semen is coming into the urethra, and some of it now, because the valve is a bit weaker going back into the bladder, it can go into the urethra, and instead of going down through the penis only, it can go up into the bladder. So that's called retrograde ejaculation, where some of it goes upwards into the bladder. It's not a big deal unless you're trying to get pregnant. Then it's a bigger problem. But otherwise, it's not a huge side effect. Contraindications: pregnancy, renal and liver disease, mainly just because of excretion. Nursing responsibilities. So this medication, again, you would try this at nighttime first, just because of its first dose phenomenon. So you try a nighttime dose, see if their blood pressure gets low, see if they have orthostatic symptoms prior to switching it to a daytime dose. So once a day pill, again, start slowly with these medications, although this particular one is a fixed dose. Tamsulosin comes in one dose, and you don't typically increase it for BPH, you just give that one dose. Unlike all the other alpha blockers, which is start slow, or start low and go slow. You start at very low doses and you go up slowly. And finally, if someone were to be taking this to help their BPH and they were started on finasteride, then once the finasteride has become effective, or it's shrinking the prostate and it seems to be effective, then they may not need the tamsulosin anymore. Tamsulosin works much, much faster. So they can have immediate effects that they can urinate better. But 6, 9, 12 months down the road, they may just be able to take the finasteride and not have to use the tamsulosin. So it just depends on their symptoms. Okay, so sildenafil is the next medication. Brand name is Viagra. So sildenafil is indicated for erectile dysfunction. So weak, ineffective erections, or pulmonary hypertension. So because it causes vasodilation in some of the arterial beds, it allows increased flow, say, to the penis, allowing for an erection to be maintained. It also helps with a condition called primary pulmonary hypertension, which we don't really know the cause of, but the underlying problem is that the small blood vessels in the lungs, the tiny little arterioles and capillaries, are very constricted and damaged. We think it's an autoimmune disease, and it results in high blood pressure in the pulmonary artery, which can then lead to right heart failure because of all the pressure that the right heart is having to pump against. So this helps with vasodilation of the small arterial beds in the lungs and reduces the pressure in the pulmonary artery. So its action is really through a little molecule called nitric oxide. So it increases the effects of nitric oxide, which then results in vasodilation and increased flow. Within the penis, it'll lead to an erection. In the lungs, it'll reduce the pulmonary artery pressure. The main effects, or the main side effects of this drug are priapism, which is an erection lasting longer than 4 hours. And that's an issue because if the erection continues, there's really no flow going into or out of the penis. So it's like an ischemic penis. It's not getting blood supply. So if left, it can damage the penis and lead to permanent impotence. So longer than 4 hours, the patient would need to go somewhere to seek help. You can get visual changes, different colors in your visual fields, and you can get alterations of your peripheral field. So it changes how, for some patients have complained of changes in their peripheral fields and color changes when using this drug. You can use this drug with cardiovascular disease. There have been a couple of reports of people getting a myocardial infarction while on Viagra or on sildenafil. But in general, patients with cardiovascular disease, they're advised about the risk, but it's not contraindicated. You can still use sildenafil. The only contraindication is if you have cardiovascular disease and you're taking nitroglycerin. So nitroglycerin in any form, whether it's a tablet under your tongue, a patch, any form of nitroglycerin cannot be used with sildenafil. Nitroglycerin leads to vasodilation of the arterioles and the veins, and in combination with sildenafil, which also leads to significant vasodilation, you can have severe hypotension and death, and there have been deaths from this combination. So usually we advise patients to take this, 30 minutes to 2 hours prior to sexual activity. and obviously to report any visual changes or any issues with or any concerns related to an erection lasting beyond 4 hours. Okay, so clomiphene. So now we're talking about an infertility drug. We've gotten away from sildenafil and other medications for men, and now we're back talking about a medication that females use called clomiphene or Clomid. And the indication for this is infertility that's related to the woman not ovulating, so not releasing an egg. Okay, so it's not going to help all forms of infertility because this medication is going to stimulate the hypothalamus, which is then going to stimulate the pituitary gland, which will then stimulate the ovary to release ovums or to ovulate. So other forms of infertility, whether it's scarred fallopian tubes, something wrong with the uterus, it won't help any of those. It's really just for inability to ovulate. And as I mentioned, it stimulates the hypothalamus to release the hormone that's going to be sent to the pituitary gland, GnRH, so gonadotropin releasing hormone. And when it gets to the pituitary gland, it's going to cause stimulation and release of follicle stimulating hormone and luteinizing hormone, which will then go to the ovaries and stimulate the ovaries to ovulate. So this medication is usually taken on about the 5th day of someone's cycle. Okay, so they had their period, and now 5 days in, they're going to take this medication. And the medication is taken for approximately 5 days. So really, it's in that window where you want to really stimulate the ovary to try and release, to try and ovulate. So what are the symptoms? So you have a hormone that's really, in the end, causing stimulation of the ovaries. So you can get pelvic discomfort because you're really causing the ovaries to be stimulated with this drug. You can get bloating. You can have like pelvic pain, pelvic discomfort. It can also cause some breast tenderness, some flushing. Headaches aren't unusual with this medication. And a lot of the symptoms will be not only from overstimulation of the ovaries, but from all the hormones being released, right? So the bloating, the breast tenderness, that's from all the hormones being released. What about the contraindications? So definitely not in pregnancy. Wouldn't use a fertility drug in pregnancy. Abnormal vaginal bleeding. Well, if you don't know why someone's having abnormal periods or abnormal vaginal bleeding, they wouldn't receive clomiphene until it was diagnosed. Other hormonal abnormalities, adrenal gland, thyroid problems. These hormone systems are interrelated. So if there's problems with the hormone or with the thyroid or the adrenal gland, we're not going to stimulate another hormonal system without finding out what is going on with those other glands. And the other thing is, the other condition is if you have ovarian cysts that are seen on ultrasound, when you have clomiphene, it will stimulate the ovaries so much that it can aggravate and enlarge the ovarian cysts significantly. Okay. In terms of advice and responsibilities, um, telling telling the patient that they have a significant chance of multiple births when on clomiphene. So if they were to get pregnant, there's a 10% chance, 1 in 10, that they could have twins. They need to follow their calendar, their ovulation calendar very closely. They need to know when day 5 is. They also need to realize that this 5-day course per month can happen in other months. So it's not necessarily going to be successful the first month that it's used, but there's subsequent months that it can also be used, because people are very disappointed when after having gone through this and having ultrasounds and blood tests that it's not that it wasn't effective that month. So they need a bit of counseling to realize that this isn't a guarantee that this month you're going to become pregnant. This medication is taken by mouth. By mouth for those 5 days in the cycle. Okay, so in this next part, we're going to talk about some medications related to labor and delivery. So remember, there's some times where we want to slow down contractions during labor. It's usually because it's a premature labor, and the infant is very young, or the fetus is very young, and there's risk of delivery of a premature infant. So medications that we'll get into, I'm sure you've heard of some of these before. Magnesium sulfate can sometimes slow down labor. Terbutaline, which is a beta-2 agonist that can be used in asthma, can also be used to try and slow down labor, because there's beta receptors on the uterus, and when stimulated, they actually reduce the contractions of the uterus. So we're taking advantage of that effect and using terbutaline to try and reduce preterm contractions. What about medications that might induce labor? So there's a medication that can ripen the cervix, soften the cervix, induce labor to start, called misoprostol. It comes as a pill. It comes as a gel that you can actually directly put on the cervix, and that can sometimes induce the beginning of labor. And then there's a medication, and it's also a hormone in the body, called oxytocin, that can increase contractions of the uterus. So there's a number of different medications that can be used, and we'll get into some of them in this part of the module. Okay, so oxytocin. The ones that you're seeing under similar, they're similar in the sense that they are used to help with inducing labor, such as misoprostol, but they're not similar in terms of how they work. Okay, so they're similar as a whole, that they're used in helping labor progress. So I just didn't want you to get that confused, since I mentioned misoprostol on the slide before. Okay, so oxytocin. So we can start oxytocin drips. and we often use it after giving misoprostol. So we can soften the cervix and get it ready for dilation, because the cervix has to go basically from a little pinpoint hole to about 10 centimeters in size, right? So that's a lot of stretching. So we can soften the cervix with misoprostol gel, and then start an oxytocin drip to start to stimulate and increase contractions. So under indications, induction of labor for sure. It's going to induce contractions, and not only that, but enhance the force of the contractions to help with delivery. It can also be used postpartum, so after the delivery, to help deliver the placenta, right? So with continued contractions even after delivery, that can help with forcing the placenta to come out. And another common indication is after the delivery, if there's significant amounts of bleeding, so postpartum hemorrhage, oxytocin can be used to force the uterus to really contract down and stop that bleeding that's happening within the uterus. Okay, so there's labor induction and increased contractions, but there's also postpartum indications for this as well. So it's a uterine stimulant, increases the strength and frequency of the contractions. And remember, oxytocin is also produced in the hypothalamus, stored in the posterior pituitary, and obviously would have this identical effect, but we're using it as a drug here, and we're controlling the dose so that we can get the exact response that we're looking for. So under adverse effects, well, if you give enough oxytocin, the uterus can contract so forcefully that you can actually rupture the uterus. Or you can have overstimulation of the uterus, too many contractions, tachysystole of the uterus, where there's just too many contractions coming at once. And if there's so many contractions occurring with such force, the placenta can tear away from the uterine wall, from the endometrial wall, and that's called placental abruption. Okay, so think of this drug that's really forcing the uterus to work hard, contracting. Sure, it could rupture it. It could force it to contract too frequent and too hard. That can lead to the placenta tearing away from the wall. Okay, so contraindications. Well, if the cervix isn't ready to open at all, that's not great, because now you're just forcing the uterus to contract against a closed cervix. The next one, active herpes. So active genital herpes is referring to herpes in the birth canal. And if a woman has active genital herpes, usually she's going to have a cesarean section, no matter what else has happened, because you don't want the infant that's being delivered to acquire genital herpes. Okay. History of multiple births or uterine surgery. So if you have multiple births, oxytocin can complicate things, because now you have two placentas, two fetuses, or potentially two placentas, and it can, with these forceful contractions with two fetuses in there, it can cause complications. Previous uterine surgery. Okay, well, there's another risk factor for uterine rupture. So that would be a high risk using it then. A umbilical cord that's prolapsed down through the cervix and is hanging out, and now you're forcing the uterus to contract, can really cause further problems with that prolapsed umbilical cord. Okay, so when the umbilical cord prolapses down through the cervix, it can get twisted, and the fetus can lose its blood supply and lead to fetal death. Forcing the uterus to contract even harder can cause even more blockage within the umbilical cord. So we wouldn't use it in that case if we realized it was a prolapsed umbilical cord. Nursing responsibilities. So this is definitely a drug that's titrated, meaning you start at a low dose and you go up slowly to see its effect. The pregnant patient will have a monitor on to see the force of the contractions, to see the fetal heart rate. Her cervix will be checked on a regular basis to see that the cervix is gradually progressing to open. Because as I said, it has to go from 1 centimeter to 10 centimeters. Okay, I think that's it for this one. Okay, so terbutaline. So remember, it comes as an inhaler for asthma. It's a beta-2 agonist. So this is, again, under similar, you're going to see magnesium sulfate. Sure, that can try and reduce preterm labor contractions. Nifedipine has been tried. It's a calcium channel blocker to try and slow down preterm contractions. So just realize that these are similar drugs that are used for preterm labor, but they're not in the same group. Okay, so terbutaline. So this is really just to try and delay things. It's not going to shut off completely the labor very often. It's just going to delay it so other treatments can take place during those 1 to 2 days that you've slowed down the contractions. Okay, so beta-2 receptors lead to relaxation of the uterine muscles. Okay, and that's what we want in this case in preterm labor. All the effects are going to be from beta-2 agonists working elsewhere in the body as a sympathomimetic. So tachycardia, okay, yep, it's a beta agonist. You can get your heart rate's going to go faster. Palpitations, you can get chest pain from all the palpitations and the tachycardia. Hypotension can occur because there's beta-2 receptors on the blood vessels going to all the muscles in the body, and they lead the terbutaline vasodilates the blood vessels going to the muscles. Okay, so you can get hypotension due to that effect. Hypokalemia, because beta-2 agonists, when they interact with cells throughout the body, they force potassium to go into the cells, so you get hypokalemia in the serum. Okay. Hyperglycemia, that's the sympathetic response to glycogen in the liver to release glucose. So you'll get hyperglycemia, right? Glycogen converts to glucose with sympathetic activation. Arrhythmias, same thing as tachycardia. If tachycardia progresses, you can get abnormal rhythms because you're overstimulating the heart so much with a beta agonist. Okay. Nursing responsibilities, definitely monitoring again. uterine contractions, you want to see them slow down and reduce in contractility. Fetal heart rate monitoring, you want to see that the fetal heart rate is in a normal range, which is an indication that the fetus is still happy in there, right? If we see huge changes in fetal heart rates, that can be concerning for fetal compromise, or something that's happening that the fetus is not happy about. Monitoring the vital signs of the mother, heart rate, blood pressure is very important. And typically this is used as a subcutaneous injection or even IV. It's not usually given as a mask or as an inhaler that we would use in the setting of asthma, for example. Okay, and this next medication, betamethasone, is a steroid. And the reason why it's in this part of a module is that we use steroids for so many things we won't get into right now. But one of them is in preterm labor. The big concern with delivery of a premature infant is respiratory immaturity. So their lungs are immature. They may not be able to breathe on their by themselves, and they may end up on a ventilator. Okay, so very premature infants can get three things commonly. So they get respiratory distress, an inability to ventilate on their own, requiring a ventilator, as I just mentioned. They can get intracerebral hemorrhages in their brain due to immature blood vessels. And they can get a severe condition in their bowel called necrotizing enterocolitis, NEC for short, NEC. And that has to do with immature and poorly developed blood vessels that's supplying the bowel, and because they're not fully mature, it leads to ischemic bowel, so death of the bowel due to poor blood supply. Okay, so in this case we're talking about a medication. So that was just an aside. In this case we're talking about giving a medication to the mother to stimulate the fetus to accelerate the production of surfactant in the lungs, so that they have a higher chance of being able to breathe by themselves when they're delivered. And it takes a bit of time to work. It's not instantaneous when given to the mother. So it can take a day or two to start to develop. So the longer you can safely stop premature labor, the more effect the betamethasone will have on the lungs. Okay, so indications: reduced neonatal respiratory distress syndrome in preterm labor. And this can also reduce the intracerebral hemorrhage that can happen in these premature infants as well. So it's actually used for both of these reasons, right? For the respiratory distress and also to reduce the hemorrhaging in the brain. And the action is that it stimulates production and release of lung surfactant, which is really going to help the lungs expand when the fetus is born, when the infant is born. It's going to help the lungs expand and to breathe more easily. The next topic to discuss is that, so this is given in 2 doses, right? So betamethasone is given as an IM injection to the mother. 2 doses spanned 12 to 24 hours apart. And really the intention is fetal surfactant production. Okay, and it's recently been realized that it also reduces the intracerebral hemorrhage rate in these very premature infants. Okay, so fentanyl, so an opioid medication, a very strong intravenous opioid narcotic, and used for all kinds of painful conditions, especially in the emergency room, in the intensive care. Um, Fentanyl is used all the time. Can use it as well as you see here in active labor, right? And it works the same way as any other narcotic or opioid. It binds to opioid receptors and reduces uh, reduces the pain. So what are the issues? Well, with an opioid, there's always a concern of respiratory depression, right? So whenever you think of opioids, if given an overdose, respiratory depression, right? And of course, hypotension as well. So in this case, it'll be neonatal and mother respiratory depression, possible maternal hypotension, because opioids can drop your blood pressure. That can lead to tachycardia to try and respond to the hypotension. Over sedating the mother. Nausea and vomiting is common in basically every opioid. It's always a risk when we give a dose of morphine or fentanyl that we're going to make the person nauseated and vomiting on top of what they already have. Okay. And of course, and remember, the oversedation is very common as well. But in general, we're thinking of giving someone an IV dose of an opioid. We're thinking respiratory depression and hypotension. And if we give too much, we'll come back and see them, and they'll be overly sedated and possibly even nausea or vomiting. Okay. So contraindications, history of dependence. So if you have someone who has a history of dependence on opioids, probably not going to use this. If they're making an effort not to be on opioids, say they were dependent on opioids, we wouldn't add this to the mix. And they probably would ask not to receive fentanyl because of their history of dependence. Okay, nursing responsibilities. So really what this is doing is giving some pain relief during active labor. So we're going to monitor the fetal heart rate. We don't want to give this very early in labor. So we want to see that there's been some progression of labor, so that the cervix should be a bit dilated, 4 centimeters. And the reason for that, if we give fentanyl early, it's going to reduce the force of contractions. It can oversedate the mother, so she has a difficult time with or cooperating with the contractions. Reversal agent, I'm sure you're aware of by now. It's naloxone. So we want to monitor the contractions, especially if they're receiving fentanyl. So avoiding early, we spoke about, because of reduced contractions, oversedation of the mother. Giving fentanyl very late in labor can be a problem, because now what's going to happen is, say there's a delivery 15-20 minutes later, the infant or the neonate is going to come out very floppy, over sedated. So because the infant also received the fentanyl. So it's a bit of a fine line, giving it in between and giving it in small amounts, not too early and not too late. Okay, and this slide is just showing you it doesn't show the magnitude of how much that cervix has to dilate. Well, the numbers do, but the size doesn't. But it basically has to go from 1 centimeter to 10 centimeters, which is an incredible amount of stretching, so that the head of the fetus can then get into the birth canal. So it really is amazing. And I think that is it for this module. I'm sorry it's gone longer than I expected. 3 hours and 50 minutes. There seemed like there was a lot of information. I've tried to keep most of them per week to about 2 hours and 15 minutes to 2.5 hours. This one just went on longer, but I hope it gives you more information.